Excellent talk by Dr. Manas. Is there any query from the audience?
Sir, we'll keep discussions after the session, sir.
Okay, thank you, thank you. Now we welcome Professor Sanjeev Gulati, sir, who is Principal Director Nephrology and Kidney Transplant, Fortis Group of Hospital, New Delhi. Sir, talk about vascular access in children, which is very difficult nowadays also. So, welcome, sir.
Thank you, chairpersons, and good morning, friends. At the onset, I'd like to thank Dr. Pradeep Rai and Varanasi Society of Nephrology for inviting me here, and also compliment them for this excellent course. I think this is the 7th in succession, if I'm not wrong, and sitting in Varanasi and organizing it literally all over the country is really creditable. So, I'll be talking to you about vascular access in children, which is essentially the Achilles heel as far as when we talk about hemodialysis in children. And this is a survey that was done a few years ago, published in Pediatric Nephrology, showing that although peritoneal dialysis is the preferred mode for dialysis in children, things are changing. And this is over 2 different timelines. This is 2001 and this is 2010. And as you can see, as people became more and more confident, with the improvements in technology, the hemodialysis is improving as a modality, and you can see even in 2011, nocturnal home hemodialysis had come up in a big way, and if at all, I think these numbers today, if a similar survey was done, would be even more tilted in favor of hemodialysis. But as I said, the Achilles heel is the access. And if your system is down, you just can't. You are stranded literally. So first of all, let us try and identify the ideal vascular access is one which delivers a flow rate adequate for dialysis prescription, has a long use half-life, and a low rate of complications. And for children hemodialysis, that's really a tall order because it's a default. It is really a default mode. Children who are not suitable sensitized patients, they are the ones who are on dialysis, and they are often on dialysis for years together. So it's literally even more important in adults. It's their lifeline. Now, pediatric vascular dialysis, the performance is literally related to the blood flow, and a minimum of 30 to 50 mils per minute is required to minimize access and filter clotting. Anything you try and slow down the rate below that, the circuit clots. Again, the maximum rate is based on the body surface area. It's 400 mils per minute per 1.73 square meter, which translates roughly, if you are dialyzing infants and neonates, to 10 to 12 mils per kg per minute, children 4 to 6 mils per kg per minute, and 2 to 4 mils per kg per minute in adolescents. So these are the different access. This is from the European Peritoneal Dialysis Pediatric Dialysis Working Group. AV fistula is definitely the modality of choice. Grafts, catheters, permacath, IJV, femoral, and they are available in different sizes, biocompatible materials. Now, AV fistula no doubt is the preferred vascular access for maintenance hemodialysis. In young children, especially under 15 kgs, the time for development of fistula could be months, in contrast to what we see about 4 to 6 weeks in adults. So you really have to plan well in advance. Second, in adults, we almost always talk about this double needle technique. But in children, we also have used single needle, where the segment is very small with a double pump system. Not very efficient, but still this is sometimes the only way to go ahead. And a single lumen catheter with clamps offers for small children an acceptable compromise between a very low extracorporeal blood volume and valuable dialytic efficacy. So, you just put in instead of literally neonates, it's very difficult to put in double lumen. So you just put in a single lumen, and then with 2 clamps with the Y connector, you can go ahead. An Apatex survey that despite all this, majority of these children start with a central venous access. Only 12.3 in their survey had AV fistulas when they were starting. So AV fistula needs to be considered in all pediatric hemodialysis patients, and the rates can be improved through a multi-D team, and Manas has given us very exhaustive talk about how he has roped around a multi-D team and built it up at. But it's even more critical as far as, children are concerned. And as I said, time to maturation up to 6 months. So should be done well in advance. Non-dominant forearm. Vessel size is very important. So Doppler study is mandatory, and it's been shown that if the venous diameter is below 2.5, then success rates are very poor. And obviously you need a very good surgeon who uses intraoperative adjuncts like loops, microsutures, operating microscope, microsurgical techniques, and these have come a long way now, and the surgeons really do a great job. Some practical tips on access malfunction. Again, this is from a recent article published in Nephrology Digest Transplant in 2019. That if an AVF fails to show maturation within 4 to 6 weeks, or it develops secondary failure, evaluation should be conducted. So the first point in a child is about 6 weeks after surgery. If the vein is deep, then surgical transposition is mandatory. And in AVF, which was just placed under 4 weeks, never try and think of an angioplasty because of risk of anastomotic rupture. If it's been there for more than 4 weeks, then definitely angiography and angioplasty is the way. In this, probably a resurgery is what we do. Now, AV grafts, yes, necessary evil, we have to fall back upon. Sometimes you can use a saphenous vein, bovine, umbilical, Dacron. PTFE is definitely the most commonly utilized because of the fewest complication rates and also easier to obtain and easier to repair. And this is a comparison between the fistula and the graft. So it's a no-brainer. Fistulas have low infection rate, low thrombosis rate. Again, whereas you can use a graft within a few weeks, fistula you can't use anywhere between 3 to 6 months. Primary failure rate is much higher in a fistula, and secondary failure rates are lower, whereas in grafts it is the secondary failure rates which are much higher. Venous catheters continue to be, the pillar as far as the access is concerned, especially if you are having an acute and chronic kidney disease. Definitely we would end up putting these catheters. And like in adults, again, IJV catheters has been shown to be superior to subclavian vein. Femoral catheter usually only for rescue and transient access if intensive care is needed because of a very high risk of infection and thrombosis. And in neonates, umbilical access, the umbilical vein is patent, so people have taken advantage of that and use umbilical access for dialysis. And permacath, about 8 French is the most preferred route for children. Survival rates, literature reports about 30 to 85% in 1 year. So these are the pros and cons of CVCs. I'm sure all of you are familiar. That can be placed easily, painless. Very important, especially in maintenance hemodialysis. A lot of children object to fistula puncture. So requires little planning, easy to be removed if it is used as transitional access, no vascular steel, and decreased risk of high output cardiac failure. Again, infection rates, failure rates, blood flow rates are variable. CV, especially for over long periods of time in children, you would end up with stenosis, thrombosis, damage to the veins, and sometimes if you are put in too deep, arrhythmias have been reported. Sites, definitely right IJV is the preferred, followed by right EJV. This is what the NK of Doki recommends. Left followed by left EJ, then subclavian, femoral, and the last is the translumbar access. And this is based on the complication rates. So highest complication rates, lowest complication rates here. Catheter position, no right or wrong choice of placement. So factors that would dictate would be your clinical expertise, the body habitus of the child, catheters, coagulopathy, intra-abdominal distension. And these are the different catheter sizes based on the weight. So they are available in any standard textbook. Again, infections remain the biggest, complications, exocyte infections, tunnel infections, bacteremia, septic shocks, bacterial endocarditis has been reported, osteomyelitis, and even epidural abscess. Especially the longer the catheters are there, the higher the risk of these complications. And sepsis rates associated with CVCs are approximately 80 per 100 patient year versus just 10 per 100 patient years for AV fistula. So that's why fistulas should be tried, should be explored before we fall back on CBCs. And again, like in adults, this 2% chlorhexidine should be used. The rest, I think, is similar. We'll skip over because of constraints of time. Again, looking at management, referral for fistula with possible angioplasty should be made if there is inadequate blood flow, compromising adequacy, elevated access, recirculation, more than 20%. Obviously, you have corrected for the needle position, ensured that if your access flow is less than 650 mils per 1.73 square meter by the ultrasound dilution technique measurement, and your ultrasound, duplex ultrasound shows a consistent abnormality, pseudoaneurysm is there, and it's recommended there should be a monthly review of the vascular access in these children. And this is the European Society of Pediatric Nephrology Dialysis Working Group Guidelines. So we'll just quickly go, a very nice article published in Nephrology Dialysis Transplant 2019. I strongly recommend for anyone interested in pediatric dialysis. So educate all children with CKD and their carers about venous preservation, irrespective of the choice of future RRT, starting from their early contact with nephrology services. At the first point of contact, a child is there with stage 3 CF4, tell them about vascular access preservation. In stage 4 CKD, those with rapidly declining kidney function or those who need to start dialysis imminently, options should be discussed, which is kidney transplant, peritoneal dialysis, home dialysis, and in West they are talking about in-center dialysis or conservative treatment. They also suggest referring children with CKD stage 4 who are being prepared for future hemodialysis to a dedicated vascular access team. So proper counseling and planning can be given. The recommendations are grade 2D. And again, very important, but often neglected, the venipuncture above the wrist in either arm should be avoided except in an emergency to preserve the forearm cephalic, antecubital and upper arm veins. And the recommendations grade here is A. Again, what is the optimal vascular access in children? We suggest that children requiring chronic hemodialysis start with a functioning AV fistula where appropriate. Recommendation is grade 2C. Reserved cuffed central venous lines for very small children depending on the vessel size and surgical expertise. Those requiring urgent or unplanned dialysis, patient preference, or where a short period on hemodialysis is anticipated before transplantation, ungraded here. And there is insufficient evidence to provide recommendations or AV grafts in children. Regarding perioperative evaluation for AV formation, this group suggested performing a structured history, physical examination and duplex ultrasound to plan for AV creation. They also suggested performing appropriate imaging of the central veins by venography, CT angiography or a non-contrast MRI in children in whom CV stenosis is suspected, such as those with previous central venous lines. Avoid AVF creation in the ipsilateral arm of CVS stenosis. Place an AVF in the non-dominant arm where possible. And they also suggested placing AVF distally in the arm and creating an AVF at least minimum of 3 months, if not longer, before its use. As I said, the maturation time is longer, so the first assessment should be done 4 to 6 weeks by a clinical exam and a duplex ultrasound regarding to plan the timings of AVF. And like in adults, the KDOQI recommends that the guidelines for fistula flow are more than 600 mils per minute per 1.73 square meter, an internal vein diameter of more than 6 as measured by ultrasound, in combination with assessment by experienced clinician in vascular access prior to first needling. Average maturation time that has been reported is 8 to 10 weeks, and children with low blood pressures may have a prolonged maturation time. So if the AVF is immature at 6 weeks, US and clinical assessment should be done every 6 weekly. If the fistula appears static at 6 weekly, then intervention such as angioplasty may be considered. Low body weight in this study by Wang et al. Was an independent predictor of primary failure. Again, no blood pressure measurements of the AVF arm to avoid tight clothing that can restrict venous flow, and to continue with physical activity but avoid sports or other activities that may cause direct trauma to the fistula. Regarding cannulation and surveillance, use an aseptic technique for AVF cannulation using either a rope ladder or a buttonhole technique. They also suggested structured physical examination for AVFs routinely performed by dialysis nurses and medical staff, a duplex ultrasound of dialysis or hemodialysis technique on dialysis flow volumes every 3 to 6 months for routine surveillance, and the recommendations are grade 2D. They also suggested urgent referral to a vascular access surgeon if there is AVF dysfunction or complication detected on clinical or ultrasound examination, and a proactive monitoring of vascular access can decrease frequency of thrombosis and hospitalization, as well as the need to revert to CVLs for dialysis access. So if you're doing this, you'll get away. Just 2 more minutes. So this is for AVF surveillance. An ABCD approach is recommended. A is assess fistula through physical examination. B stands for blood flow and change in flow from the baseline. Volume flow assessment by duplex ultrasound of dialysis or by hemodialysis techniques on dialysis. C stands for clinical problems such as difficulties in needle cannulation or prolonged bleeding after cannulation, and D is dialysis monitoring, that is adequacy, venous pressure trends, and recirculation. Prevention of thrombosis, the group suggested that antiplatelet agents such as aspirin, cyclopidine or clopidogrel given in the first few months after AVF creation reduces AVF thrombosis. It will be particularly relevant especially in the youngest children. Use of aspirin at least they have suggested in all patients for the first few months, and reducing the ultrafiltration rate for a few dialysis sessions after AVF creation, and allowing permissive hypertension by adjusting antihypertensive medications may prevent AVF thrombosis. For prevention, again, this is a study which compared TPA versus heparin, and so they suggested that TPA should be used as a catheter locking solution to prevent catheter thrombosis, but cost issues are there at least in our country. But this study found that there was a 2.4 times less clot formation with TPA than heparin when present, and the clots were 1.9 times lighter, in the TPA group. Prophylactic warfarin is safe and may improve CVL survival in children at increased risk of thrombosis, and they suggested that TPA should be used as a thrombolytic agent as far as CVL thrombosis is concerned. So to conclude, vascular access in pediatric hemodialysis patient is challenging but necessary, and it is an very important undertaking for the nephrologist. Advanced planning is required, minimum of 3 to 6 months, a multi-D team, and minimize or avoid the prolonged use of CVCs due to risks of infection and the need for vessel preservation. So the issue is not who places the access, who does it right every time to everyone and everywhere, and these are different choices that are available: a transplant, dialysis, or a peritoneal dialysis, and some of these children are from SCPGI. So very important that to plan well in advance and counsel these children, because these children are not very happy with getting their fistulas